Good morning and welcome to ccclivecases.org. I'm Samir Mehta, the moderator for the cases. This is session number 17 and session number 3 with our new affiliation and partnership with theheart.org. I want to first of all thank so many of you who have sent me some very important feedback, and based on these specific recommendations, we have continued to modulate and regulate our bandwidth, and this is going to translate into 3 clear improvements. You'll have improvement in the live streaming quality. We have also made dramatic turnaround time decreases for the archive videos, so they should be available at very short intervals. And finally, there is a slight change and improvement in the format, which will hopefully help you follow the slides simultaneously with the live case. This morning I am also happy to announce that we have a live audience. We've converted the CCC live cases into a viewing theater, and I'd like to welcome at this stage Mike Young and his team of the international delegates from the medicines company who are attending Mount Sinai Hospital as a preceptorship program. Please keep sending your questions, info@ccclivecases.org. And Samin, good morning. I see you have another challenging case this morning.
Of course, and with my team here, Anu and Pedro, come just to welcome all. And clearly, as you mentioned, that we have made a new improvement on the heart.org website. Really, the lot of issues were the pictures were small, but they really have been enhanced with the size as well as the quality. Now, with that note, today we actually have very handful agenda, full agenda, because a lot of things we are trying to show in this particular case. And I welcome all our viewers and of course the live audience at present in our conference and control center about this case, and hopefully the tips will be provided during the case. Now with that, I'll start with the case, the history. That is, the patient presented earlier this month with inferior wall non-STEMI. It's a 83-year-old female who has 3 vessel and left main disease and EF around 30%. Underwent DES of the culprit vessel, which was right coronary artery, using 2 Zions V stents. And since then, patient continues to have some mild chest pain, limited activity. She goes to shopping mall and so, but has angina with mild shortness of breath. History, multiple risk factors with the diabetes, which is insulin requiring, hyperlipidemia, hypertension. She has colon cancer and so, which has been under control, GI bleed, and abnormal stress test was last year, which was managed medically until this month when she presented with MI. And of course, she is on optimal medical therapy now. This is since about a month now on since her myocardial infarction. Now basically, we'll show the angiogram. This patient when presented had a 3 vessel and left main disease, and ejection fraction was 30% with a syntax score of 41. And clearly the extensive disease, which we'll emphasize on the angiogram. And RCA was the culprit, ulcerated subtotal thrombotic lesions. Anu put 2 stents, patient went home 48 hours later, and as I mentioned, continues to have angina. Now what we also do, knowing that although this patient is the age group where you may not have much choices till we have some new antiplatelet therapy, but we still try to test patients before going home next day after giving a loading dose and maintenance dose on the verified now assay with the platelet reactivity. Now she actually had a 17% platelet inhibition with PRU was 302 units, and we are actually testing again, and we'll let you know in few minutes where we are. Now basically today patient is here for the left main and LED intervention using Impella LV assist device, exactly because of what shown in this angiogram. If we can turn to our cine, live cine and fluoro. Now you can see here, this is the region that we want to emphasize of the use of the LV assist device, particularly Impella, in this high risk patient because of LV dysfunction. Again, alone LV, as I mentioned, it will be a combination of 2, complex anatomy and LV dysfunction, so that this LV is about 25-30%. But clearly also the complexity of the angio. This is the 2 stents in the right coronary. Always our principle when patient comes back for stage intervention, we always take a quick picture of the vessel which was done. I know many centers don't do it if patient comes within short time, but we at Sinai is a protocol that when patient comes back for the second intervention, you need to take a picture of the first always, and this is where it looks great. And now this is the case, vessel in question. Actually we'll get a better picture of it. This is a long multiple lesion calcific, particularly at a 3 o'clock area of the LAD, right from the proximal LAD, mid LAD, distal LAD. Then there is a disease in the ramus as well as proximal circumflex, and about 60% lesion in the mid left main. Now you can see here, I think this picture really provides a clear depiction of the calcific nature of the disease. Moderate left main, you want to call it a 40 or 60, but it's in that range, 50 plus minus 10, multiple LAD lesions. Patient had the circumflex, the stent
was many years back,
many years ago with a bare metal stent and remained fine, but has developed the disease little proximally. And the ramus. Ramus is there, but taken overall our goal was that if we concentrate ourselves in only the left main as well as in the LAD. Now there are disease some other vessels, but that can be taken tackled later on. So in this case, bad LV bad by definition from my point of view less than 30%. And secondly, complex coronary anatomy justify to use some assist device beyond balloon pump. So that Anu, you are ready to do.
So,
and the question comes is the very important point that this patient has a syntax score of 41 when presented, but you know anybody who is more than 80 years of age, we know that surgery even with a high syntax score is unfavorable, higher incidence of cabbage, lot of reluctance from the family. So that even that time we did ask the patient, and of course patient has a because of the only issue in this particular case, although you could say the LV dysfunction, but LV dysfunction alone should not be a contraindication because studies have shown that cabbage patients will do very well even with the LV dysfunction. But the age, because of age and acute coronary syndrome, patient had a PCI that time, and now syntax score now is about 36 because 5 was attributed to right coronary artery, still remain high. We did Anu actually asked the patient and the treating physician in terms of option for having a surgery, but clearly because of age, patient declined. And I'll come back to this point also, and the emphasis on our today would be, as I said, this is a very the full agenda, and purpose would be that try to provide lot of slides, not necessarily go through all of them, but they are then available for audience to download and use in their practice. And that points are LV support for high risk PCI, who should get it. Then the whole issue of the Clopidogrel non-responders or high platelet activity on Clopidogrel, plaque modification in calcific lesion like this, and then appropriate revascularization choice in patient with high syntax score, where we are at Sinai. And of course, I have brought our expert in the newer imaging modality, which is the infrared spectroscopy lipid scan. We have something new we'll try to show today with Pedro Moreno, who has clearly the intellectual feedback in developing this technique which has come to the clinical use now. Okay, with that note, I think we should be ready to start our Impella. You want to put Impella live first?
Yeah.
So Samin, this is as complex as it gets. Elderly patient with the previous PCI to the right, high syntax scores, calcified vessels, left main.
So if you can show this angiogram on the left side, I think the most important point before Impella insertion, we got to make sure the vasculature will be able to take this device. The 13 French sheath, before doing that, which what we do is an angiogram, as you see here, and sheath has been inserted, a 13 French sheath has been inserted, and then you have
I know you're using the microcatheter for all Impella. Excellent.
This has been the rule with this new batch of fellows that every procedure is done with the micropuncture technique, and because it's almost between 1 to 2 French. If
at this moment you already have the access from the right groin.
That's that
so
will be for
have you initiated any anticoagulants here already?
The way we do it is go to the left side, we do the side that requires Impella, we do the micropuncture, take the picture and insert the sheath, followed by the contralateral which would be for the PCI, either the left or the right. Once the sheaths have been inserted, and if we don't need any venous access, at that time we give the anticoagulation, which usually in this case is an angiomax, bolus and drip is going. The sheath already a 13 French sheath has been inserted on the left side, and we actually have an angiogram from the last side that last time that she does not have any tortuosity in the iliac or aorta. We have the GR catheter already sitting in her ventricle, and then we have this stiff wire which is provided by them. Yeah, the other point we had to make is that we have a pre-close that has already been done. If you can show here.
Anu, are you using that as a standard technique to put the pre-close before Impella?
Before, yes, that is a.
And two of them?
Two.
You can get one more in the plate. Good, then fine. Yeah, and that's an important point because now with the bigger devices, particularly now the TAVI using 18 French with the core valve, we expect to start by next month. Clearly that this large catheters pre-close, whether use the two pre-closes or other devices becomes very closure devices become important. And so all our valvuloplasty patients at present, which are 12 French, gets the pre-close, and then of course Impella devices and so, yeah.
Anu, there are reportedly many improvements which have been made with the left ventricular assist devices.
Yeah,
both
I'm just going to go over the important ones. One, what they have done is the insertion itself has been made very easy. This cage, which was a difficult one to get the wire through, it's very easy, and you in the past you needed two people. At this time a single person can do it. You see this curve, all you have to do is have your two fingers behind it, and with your thumb, with the proximal portion, you hyperextend it so that your wire will go through the cage, will come out through this. This is exactly where the motor is, where you have to be very careful, and your wire exit has to be right at this point where you have the black line. And this is the most important part. This is all you need in the insertion, that the wire exit has to be from this particular housing which comes out, that has to be parallel to this black line, and that's all you need. And when you're in the whole device gets through the sheath, again there will be a lot of bleeding. You just have to be careful and negotiate it slowly through all the tortuosities. And this whole catheter comes here, and you have a quick setup which is color coded. So this one goes to the console which you give to the tech, and this particular tubing is connected to the dextrose, which is 5%, 10%, 50%, sometimes even saline if you are in the setting of an emergency doing cardiac shock patient, and just you connect the red color to this part of the catheter and the yellow to this. Is all color coded, very easy, and the setup is ready. It will be usually a couple of minutes to get this setup ready.
So even for some of these patients with cardiogenic shock in the midst of STEMI, you are not going to be losing too much of your door to balloon times with the setup?
Yeah, no, not with the current setup.
So you'll show us exactly the wire exit?
You hyperextend, and
excellent.
You make sure you're coming out at the right portion.
And we see the wire exit coming just proximal to the motor.
Good.
You see it?
There, yes, we do.
Yeah.
Okay. And then key is that the shape of the Impella is like a pigtail. I know there are a few reports of even wireless insertion.
Show here.
It's just like a pigtail, when you can advance the pigtail into the ventricle without the wire. Same thing, that you can advance the Impella also.
So one person is holding the wire. As you're going in, you will see there'll be lot of blood coming out at this point. You just have to keep going in. You may hit some resistance, a little resistant, but just with a steady forward push, you keep going. Now, if you know there is some tortuosity, calcification in the aorta, it's best that you fluoro as you go up, and now you are entering through the aortic valve. Since this is a short monorail, you may see it. At this time, you can pull the wire back a little bit. So, the pigtail.
Almost as easy as advancing a pigtail in diagnostic catheter.
That's it. That's the learning curve.
Now, when your motor is right above the aortic valve, actually this particular console does not tell so, but the newer console which will be released to Mount Sinai according to them end of this month, that tells you everything. And now once you are in, you take out the wire, and how are we doing there? The console will usually tell us, are we too in, do we have to pull back? It gives us the pressure tracing. You can show the console. Now with the AngioMax, our ACT has been 347.
Anu,
You need, even with the AngioMax, as long as the ACT is above 300, we are okay. If you are using heparin, it has to be above 290.
Anu, are you simultaneously going to measure with the right heart catheter, or you feel comfortable there is no need?
No, I think as long as the wedge gives us an idea. Actually, if this patient's wedge is low, she has been well treated. EDP was not wedge, EDP was 5. So we had to give her fluid bolus. Yeah, if it is less than 15, then Impella may give trouble when it's trying to extract the blood.
That's a very important.
Routinely, if we are using it for clinical purpose, we do not use a SWAN. But right now, if as a part of a trial, the protective, they still are using right heart pressures to see what happens compared to balloon pump during and after the procedure.
Anu, how rapidly do you go from the phase 1 to the phase 8 with the?
Right now we are they already gone up. They give 1 minute, and they keep going up, and depending on how the patient's blood pressure is. Here we may see some hypotension because she was volume depleted, but otherwise they go up all the way to P8 within a couple of minutes. And the same thing at the end of the procedure, as your procedure is coming to closer to a finish, give them 5 minutes gap and tell them that you are finishing the procedure. As long as we know the patient will not require Impella later on, they will start weaning over a period of 5 minutes to go down to P2, from P8 to P2. And the maximum you get now will be 2.5.
Anu, excellent demonstration of all the teaching points with the Impella, and I have always been impressed as to how user friendly and easy it is to place. Same, whenever you're dealing with the elderly patient, we are using the Impella, the same 3 contraindications you have to be careful with: the vascular disease, the LV thrombus, and any severe aortic valve disease or anything additional?
Aortic valve disease, mild aortic valve disease up to 1.5, they say you can use it, but more contraindication if there is moderate to severe AI. Mild AI is okay. And how user friendly this device is, that we have used in patients with tortuous aorta, patients with aortic aneurysm, and patients who have had stent graft inserted. You have the stent graft inserted, and we have done Impella on patients even with the stent graft. It was easy to negotiate it through the stent graft.
Okay, now if that's okay with what Anu is going to do now is go with the guiding catheter. This is the picture. This is what we are going to interrogate by the IVUS as well as the infrared, and that's where we'll need the expertise from Dr. Pedro Moreno. But let me go through what we usually do. Anu, meanwhile, you can go ahead and take your pictures and ready to decide what we are going to do subsequently while doing IVUS. Then we quickly go in the next 7-8 minutes on all our topics of this high-risk PCI, that which patient with LV dysfunction and complex anatomy. And that's very simple. That when do you use in cases? Cardiogenic shock, maybe hemodynamic instability, but otherwise combination of LV dysfunction and the patient with a complex anatomy. Of course, we have 3 available devices: balloon pump, the PTVA, and the Impella Recovers 2.5. percutaneously, which is 13 French sheath. Actually, the catheter is small, the 9 French shaft, but the sheath is the 13 French and the 11 French the catheter. This is as has been shown. Now, this is a little miniature explanation of the device itself, which we have Anu has shown beautifully, that goes retrograde, inserted, and the motor is in the proximal end. That basically taking the blood out of the ventricle and ejecting against the aortic valve. So, basically the purpose is that decrease the overall myocardial workload, improve the coronary perfusion, improve end organ perfusion, and therefore in these hemodynamic patients that you are getting a full support during the intervention. And one of the important point of the device is that it let you do a complex case with ease, and that's the key, so that you can not need to rush because of hemodynamic issues, that you complete your work as it should be done, otherwise with a full and successful intervention. Now then, there are a lot of data of the support of the Impella, and actually the latest being by USPAP Registry presented at TCT by Bill O'Neill of basically all patients who are getting Impella in the US. They made the part of the USPAP Registry just like Europella in Europe, and majority of patients, as you can see, that being used for high risk PCI, 2/3 of them for high risk PCI whether elective or urgent, and about 20% for shock patient, and we will show you the data based on both of them where we are. And actually more important that this will be all available on the website for anybody who need to inquire it later on. And the typical high syntax score patients, these are the truly high risk patient with a 36 syntax score, STS score of 5.6, and there is an improvement in the LV function. That what studies have shown in this high risk group, that there is an improvement in EF from 30 to 35. This goes back with the other data published on the PROTECT trial earlier also, and improvement in the heart failure symptoms. So very important, that significant 49% of the patient improved by one or more NYHA class. Therefore, clearly the symptomatic improvement, overall MACE rate was 8.2% at 30 days, and follow-up of 1 year, elective versus urgent, overall about 90+%. So very, very important that even these high-risk patients, good 1 year survival because of complete revascularization and so. Second part of the MI shock registry of the USPAP, and that basically that more and more patients now, we are inserting the Impella before the balloon inflation. So clearly there is a difference when you put an Impella before the PCI or after the PCI, and this actually has shown also that various hemodynamics improvement, very significant, and the basically improvement in the cardiac power output, which is the combination multiplication of cardiac output and mean arterial pressure, and it leads to improvement in the hemodynamics of the systolic blood pressure, diastolic blood pressure, and the mean arterial pressure, and 30-day mortality. Impella on pre-PCI 23%, and Impella after PCI is 56. So the point is, in a cardiogenic shock, you should start with the Impella, and of course some small group of patients where they have a follow-up paired LV function, there was improvement in EF from 26 to 31, which is 19% improvement. So this basically comes back to our slide. The combination of the EF and complexity of the PCI leads to where these devices should be used. Clearly that with a good EF, you have a lot of leeway, maybe balloon pump is good enough, but in the very severe LV dysfunction, our case will be in this kind of border that your complex intervention you should do with the assist device, reason being that the goal there is to have a successful full revascularization. In the middle group, which is the LVEF of 30-35% and below, that's the part of the PROTECT 2 trial, which is more than 2/3 completed, will answer the question whether balloon pump is good enough or you need an Impella for those cases. Now then issue comes of the Clopidogrel non-responsiveness. Very nice article in this month of JAC about high on treatment platelet reactivity. This all mediated by P2Y12 receptor on the platelet surface. Basically the ADP receptor, that activation of the platelet cause thrombosis and ischemic event, and what we have used for the years, Clopidogrel has issues at various levels, from absorption from inhibition, the drug-drug interaction, and various enzyme, the genetic polymorphism of the individual cytochromes leads to worse clinical outcome because platelets are, the active metabolite is not available. So the less active metabolite, so that there is non-responsiveness, and this leads to a wide pharmacodynamic response, in many cases having an event. And that basically has led to the come up that yes, high on treatment platelet reactivity on Clopidogrel is associated with higher event rate. This is the busy slide, but really answer that question, what should be the cutoff? 235, 230, the various are in the literature. But seems to be that once you are high reactivity on the Clopidogrel associated with a bad outcome, again shown in this slide. And therefore, this kinds of puts it together that what should be the ideal inhibition. It seems to be 40% platelet inhibition on the maintenance dose is ideal. Now, you could have better, but higher the inhibition, higher will be the bleeding. So the 40% seems to be a nice cutoff, and this is what actually you can do it in the Cath lab. Verify now assay by Acumetrics, you can test it in the Cath lab, and it gives you the readout of the platelet reactive unit, which is PRU. And basically your inhibition should be more than 40%, and if it is less than 40%, then we call it a hyporesponder, and so, and therefore biggest issue comes when hyporesponder, that is patient taking the medicine. Many times the issue is because patient not taking Clopidogrel, and of course the interaction genetic testing, and in these patients, those who are non-responder, what we should be doing. And the issue remains is, can you increase the Clopidogrel dose, or we have the newer oral agents of the Procedural and ticagrelor. Now clearly, as you remember the OASIS 7 trial, they basically in acute coronary syndrome patients, they double the dose, and this is the height of the red bar, clearly answering the question that can, by doubling the dose, not testing for the platelet reactivity, blindly just as a strategy for 1 week in acute coronary syndrome with the PCI, yes, you are able to decrease the event from 4.5 to 3.8. There was actually interaction with the high dose aspirin in that group. But more important is, yes, that answer is in many cases, but we also have subsequent pharmacodynamic studies that in all cases, your doubling the dose will not eliminate this unresponsiveness. Almost 12-15% of patients still will be hyporesponder. So then there are at present many trials are ongoing at this point, and today the major trial of the Gravitas, actually many of them I have shown here, the Gravitas will be presented in ACC, in AHA today in Chicago, which will answer this question that if you are non-responder, your platelet reactive unit was less than, more than 230 or 35, by tailoring the regime, by giving additional dose of Clopidogrel versus standard therapy, and compare against the patients who are responder, is there an event rate difference at 30 days and 6 months? Very, very major trial, and lot of eyes and media is waiting for the result of this Gravitas, which will be, I think it was supposed to be present today, this afternoon. Very important, because the whole concept that can you change the responsiveness with the high doses has put to the test in the randomized fashion. And the issue then question comes, then of course you can use another agent, which is Procedural, which is very effective all across the board. No effect with the genetic polymorphism, no effect with the proton pump inhibitor. Higher the event, higher the risk factor, diabetic patients, STEMI patients, higher is the benefit compared to Clopidogrel as shown in this slide. Now, big issue was, yes, it's good, but cause bleeding. And this is where there is an interaction they found that if patient is less than 60 kilo or more than 75 years of age, had a higher bleeding as shown in this slide. Therefore, if you combine those patients who are older age, less than 60 kilo or history of TI or CVA, those have very high risk of bleeding, actually also with the Clopidogrel, but clearly with the Procedural more. But if you avoid those, then those are the ideal cases, in my opinion, where efficacy is higher and the bleeding is lower. One very important point, and which pertain to this particular patient, and that is patients with diabetes who are elderly but did not have a stroke or CVA. Clearly any type patients at TIA, CVA, it's contraindicated. But if it is not the issue, but older age, but have a complex or acute high-risk coronary syndrome like this particular patient, should you be using Procedural? And this actually shown that if you take diabetes and more than 75 years of age, actually you see the benefit is much higher, the almost 6+% reduction in the primary efficacy endpoint. So, the very effective. So, yes, in selected cases or even older age, you can decide about the Procedural, but use a 5 milligram dose, not the 10 milligram, 5 milligram because that has shown to be effective. And this actually is our protocol. Many people ask us what is the protocol at Sinai, and this is what available on the website, and anybody can download it. The second drug for this platelet sub-study, just again presented in JAC last week, is the Plato platelet sub-study. Same thing with the ticagrelor compared to clopidogrel. Clearly, as you can see, no matter how you test it, by using ticagrelor, you have a good inhibition of the platelet with the drug compared to clopidogrel. So the very reliable inhibition. Then issue comes the modification with the calcified lesion. We have shown multiple times. Extremely calcific lesion with a rotablation, moderately calcific inelastic lesion by using a atherotomy of either cutting balloon or angiosculpt. And then issue comes how do you change your correct practice with the syntax score, and simple, which is angiographic score of the lesion complexity, and they divide the lesions based on syntax based on 32, less than 22, 23 and 32 and more than 32, clearly because there is a gradient. Now you see, if once we are now the 3-year data presented in TCT last month, that if you are low score, the Cabbage and Texas DES actually overall point of view, you can see here that no difference or non-significant difference in favor of Cabbage in the low tertile, but in the intermediate tertile, we kind of start losing to the Cabbage arm. And that basically the significant difference between Mackey, and not only, also the difference in myocardial infarction, significant higher MI in the PCI group compared to Cabbage. This is the overall syntax score of the intermediate, and in the large 33, very significant. So that clearly that the hard end point in a high syntax score of 33, that Cabbage is better than PCI. And they're slightly different with the left main. It's a more for multi-vessel disease. This is the slide I showed last month, that even syntax score 33 of the left main had led to a protocol, again protocol, Mount Sinai, Cath lab. We got a lot of feedback on the heart.org website that people are very happy that we share our protocol with everyone. Like that people, many centers may not, but we want the way we are, we want everybody to be like that. With the very low complication and yet provide the best care, so that available on the website. So clearly this is the protocol of Mount Sinai with the syntax score 33, not a high risk for and the patients who are not high risk for Cabbage. They come out of the room and the decision is made with the surgical consultation that patient should go preferably for surgery. Then issue remains, and this is where the major the new advancement which we'll show here is the newer imaging modality of the infrared spectroscopy and lipid scan. And I give now mic to Dr. Moreno, who is the expert in this field, and will do this case.
Samin, outstanding review. Pedro, welcome. You really don't need any introduction to our viewers. Tell us more, educate us. What advancements does this make towards the vulnerable plaque?
Well, it's a pleasure to be here. Thank you for the invitation. The issue here is that we have learned that plaque composition plays a major role in decision making, mostly in cases with high plaque burden, like in this case today. And we also learned that the ultrasound cannot provide the actual plaque composition that we want in the cath lab. So we developed a new technique using, instead of sound for ultrasound, we use light. So light is, the unit is the photons, and it can activate the tissue so the tissue can absorb the light and provide a finger trim, basically a finger signal that will tell you if it has plaque composition is lipid rich. So this device was developed in the 90s, tested in the experimental lab, both in vitro and in vivo, and then approved by the FDA 2 years ago, and now in use in the cath lab. It's called the near-infrared spectroscopy that uses diffuse reflectance. You can see in the slide that light travels very fast, and we use the electromagnetic spectrum, which in the center of the slide you see the visible light, and then you see the infrared light, and near the infrared light there is a spectrum that you can test for plaque composition. So this slide shows how it works. It illuminates the plaque, in this case with laser light. You illuminate the plaque, and then the plaque absorbs the light, and what is reflected is plotted in this plaque composition slide, when you can do the principal component analysis and identify simultaneous non-destructive under less than 1 second for chemical, biological, and even molecular information. So this device is only in this case to identify the lipid-rich plaques. We tested it ex vivo in this publication back in 2002, and we tested the necrotic core, the thin cap, and the macrophages for the classical vulnerable plaque. And you can see the sensitivity, specificity, and the positive and negative predictive value highlighted in yellow for the necrotic core. And the company made the decision that focus on this very highly specificity and sensitivity to detect necrotic core. Then the catheter was developed and was tested by Dr. Vermani in coronary samples from humans. You can see on the far right a very large positively remodeled lipid necrotic plaque that is highlighted in yellow in the screen when you pull back with the catheter in the coronary. This is an in vivo case, and you can see an extensive plaque burden in the LAD, and everything you see yellow means a large necrotic core that will allow us to get very reliable plaque information regarding composition. And most recently, this device has been very reliable to detect what we call the napkin ring of the necrotic core. In the upper part of the slide, you can see the amount of yellow. In the lower part of the slide, you can see also the amount of yellow that is really massive. It's all 360 degrees, and therefore these plaques are prone to embolize. This is the basis for what is called the canary trial, in which in a randomized fashion, plaques like this with very high risk of embolization will be tested with a protective device, specifically the umbrella, to see if you can reduce the CPK release and the troponin.
Good.
So for us, it's going to be of significant value to know the plaque composition, and this is what we're going to do today, this morning. Thank you.
All right. Good.
Pedro, this is a wonderful introduction. We'll get you back here for more in-depth evaluation, I'm sure, in several numerous cases, but looks a fairly easy scan to interpret.
All right, Anu, you tell us what you're doing now.
Yeah, this scan has a little another complex way of preparing. It's a very huge device if you look at this. Take that blue thing off.
Pedro, in the meantime, when you mention all you're looking for is identifying the yellow, or are there different contracts of yellow?
Take the whole
Yeah,
plastic.
the purpose is to identify the yellow. Yellow means large necrotic core with the 1300 nanometers in the wavelength. That is the type of necrotic core that is the high risk for plaque rupture and also for embolization.
Okay, this is a very important part of the preparation. Is your plastic has to make sure that you are okay at the distal end as well as in the proximal portion where you're going to connect. And the catheter comes with a little knob. You take the knob, you place it here, and then you take the entire catheter. You see the purple portion which faces up, and as soon as you insert the catheter,
Pedro, is this the large sizes because that is the equipment that is doing the acquisition of the images?
Exactly. When we started to do a spectroscopy, the spectrometers were the size of this room. And to miniaturize the device to make it handy for this is really 10 years and 80 million of investment in a company that were able to bring what was a huge device to the Cath lab. And it looks bulky for us, but the tremendous amount of research and development that was involved is actually fantastic to have it for us in the Cath lab.
so you got to make sure your knob is all the way so that the scanning tip is at the distal portion. You have two lights that you see here, and
in this particular case, maybe Pedro
Again.
can point out, knowing the diseases, left main, little bit of proximal LAD, we know mid to distal LAD is very calcific. Maybe we can just scan the proximal area. They had done the IVUS, and Anu will tell us about the IVUS finding, that what this infrared spectroscopy lipid scan will help. Means if there is a yellow plaque, then we will have more lower threshold of stenting the left main. What do you think?
That's a very good question. I think you still need to rely on your minimal luminal area for decision making in the cath lab. So if your minimal luminal area is less than 4 in the major arteries or less than 6 in the left main, then you might need to take care of this plaque by IVOS criteria in 2011. Yeah. Now, it is important to know the plaque composition in borderline lesions because you can embolize first and second. If you leave these yellow plaques without covering, you will see a high end of edge restenosis in these plaques and sometimes acute coronary syndrome with the stent thrombosis.
Okay, very good point. Very good point. I think that's knowing that the decision is already there. That we have it. Yeah. That now while we are actually they're showing the picture already.
Yeah,
okay.
It's just a scan. Actually, you will not see the plaque composition until your scan is complete, and then you will see it at the end.
Now, if we can just narrate what was on the IVOS.
Yeah, the IVOS, there was diffuse disease, calcific disease. Actually, if you see it, like this catheter, even the IVOS catheter would not go distal from at the level of the mid LAD. IVOS catheter would not go any further, so that's where we started doing the IVOS. Yeah. So the tightest area was 2.7 cross-sectional area with the
pronounced calcification there.
Yeah. Not deep calcium or superficial calcium, and at the left main we have a cross-sectional area of 6.4, the mid left main.
So I think that's a very important information that if on the spectroscopy we don't have a yellow plaque, the lumen wise it does not make a criteria as you mentioned that MLD point of view, so that if okay, you could even leave the left main with the moderate left main in this particular case.
Absolutely. Okay, the other advantage that is presented today at AHA is the combination of this infrared with IVOS.
There's not a lot of a yellow plaque in the scan.
So Anu, is your information both with the near as well as with the IVOS consistent in this case?
It's two different things. Actually, what infrared tells you is all the plaque consistency. Like here, what it has told, if you are you showing the infrared? Yeah. If you see that,
now.
That's the cross-sectional area of the vessel that you're seeing. This is a cross-sectional area of the vessel that is being shown. This is mid LAD, and this all the way to the left main. This is maybe the left main plaque. So if you see the yellow, it just shows the lipid-rich core is very minimal. Lot of it. Actually, I think Pedro Moreno, you can tell if you do virtual histology with this, what it will tell us that this is not the vulnerable plaque. It is not the red plaque that we need to be concerned about. Most of it is a fibrous, fibroatheromatous plaque or calcified plaque.
Exactly. What Anu is saying is when you don't see yellow, you probably have a collagen or calcific plaque. You don't have a big necrotic core. And actually, we can measure the amount of necrotic core with what is called the LCBI, the lipid core burden index, which in this case is only 26 points. We have cases with 80, 100, even 600. It depends on the amount of lipids. So exactly, this plaque is going to be fine clinically. It's very unusual that this plaque will give you thrombosis. And if you can treat the obstructive lesion percutaneously, you are confident that this patient should do fine in the future.
And this may be sometimes, you come across patients where their cholesterol level is normal, their HDL is normal, the LDL is okay, they are on statin therapy and still continues to have disease. This is the kind of disease that you see is fibroatheromatous plaque in their vessel, and not that is the one that's going to respond to cholesterol therapy.
Exactly right. We are testing here with the leadership of Dr. Kinney, who just spoke, a very important clinical question, which is in the severe lesions that we stage, if we can modify plaque composition using this device and very aggressive lipid-lowering therapy, so you can test within 6 to 8 weeks the response of the plaque composition with the aggressive, in this case, statin therapy. Most importantly, this device has been also used for randomized trials as well.
Pedro, excellent. I'm sure we'll be using this device many times more and continue to learn from you.
Thank you.
Samin, in the meantime, we did a quick check. The results of the Gravitas trial will be posted at 10:45.
Ah, 10:40, yep.
Anu, you are additionally challenged today by being exceedingly complex case with the reduced time.
With who? Sorry?
You'll have to work speedily today because of all the new technologies we've shown, but
close the flush. Yeah, it's actually close the flush a little bit. Yeah, that many times what happens in this, we did all the testings on the regular our run-through wire, and now we are inserting the rota wire, which is sometimes a little difficult to go. It's not that as user-friendly. So many times we need to go
Wait.
we need an additional, same exchange length catheter.
So, I mean, the plan is, of course, just to address
because of the calcium, yeah.
Right, address the LED.
But key is that very simple that you need to use this clip. That many times, just like a torquer, we don't want to use the torquer, but clip is required for advancement because the wire, of course, as I mentioned, that one of the big work has to be done in terms of the improvement in the overall the wire of the rota that it is into the branch, which is okay. Good. So now the wire actually has been advanced. Open the flush again, and very careful. Many times when you are in a rush, and so make sure the rota flush is always dripping.
So, I mean, 1.5 or 1.75?
175 bar.
Yeah, 175. Now, very important that people ask that what should be the burr size, and so it's usually 0.4 to 0.5, and 1.25 burr will use only in cases where you don't see the distal vasculature or your exchange catheter did not go, then 1.25. Otherwise, majority of the cases are between 1.5 and 1.75. The case which we did in September here, we had a very large vessel, and we used a 2.25 burr in that particular case. But usually, 90% of our cases are between.
Don't check.
Yeah, 90% of cases are between 1.5 and 1.75. Okay, now wire, we can pull the wire a little bit. The wire has a tendency to go. Yeah, let me see. Okay. Once you're there, I'll pull the wire a little more. Now there again, it's a two-man's procedure that you have to good. Now you see the wire actually has gone further. So as long as it's remain in the main vessel.
Impella is at P.
Yeah, keep going. Okay, we are ready for the rotablation now.
We did the 3 steps here.
Go. Now basically the speed usually about 150 RPM. Pressure go. Now as you can see here, the time to time when it pulls back, I do a little flush. The purpose there is the downstream clearing up of the debris. Now this is the biggest calcific area. Now many times when the wire comes back, you can press the brake and advance the wire manually. And this is the tightest point. Good.
Anu, how is the patient tolerating the rotational ablation at the moment?
Ready? Saying, what was the question? Sorry.
How is the patient tolerating the?
Well, actually same. This is the whole advantage of this assist devices. You can imagine this patient with that LV dysfunction, completely fine. The blood pressure still remain 120, and so tolerated very nicely.
And not a single drop on the blood pressure, not even a 5 millimeter drop, not even a change in the heart rate, everything completely stable during the whole rotablator of the whole proximal and mid LAD. Only because of the stroke volume that is fixed and actually very good with the Impella device.
Pedro, read out to me how much is the augmentation you're getting now?
Well,
what augmentation we have?
It's I mean right now the systolic wire came back. That's okay. Let's go with the blood pressure now actually has become 160.
2.1 liters. We're having 2.1
1
liters
liter.
on the device. So the device is, the motor is giving you 2.1 liters per minute extra from the stroke volume that the heart by itself has. So it's at least 50% or so of the stroke volume for this patient.
So, I mean, you'll exchange the wire or go back with the...
Yeah, no, definitely we basically, I know some investigators try to do it on the rota wire. We never do. And we'll go with our workhorse wire, whichever will it be.
You're satisfied, you think you've ablated enough?
Yes. Yeah, usually 1.5. Basically, I may leave the wire in position sometimes, kind of using a modified poor man's cutting balloon situation.
But you thought that the mid segment had...
1.75 bar, yeah, 1.75 bar with a bar to artery ratio, making it about about 0.4 to 0.5 in this 3 millimeter vessel. 0.5 is 3.5 is very good. Yeah. Now clearly that happens with the guide catheters staying in the body for a while. They become a little soft, and therefore we may end up in putting a new guide, although we just went in.
So, I mean, there's an important question which has come up at this moment, which I'd like you to address. How are you dealing with the renal function in the elderly patients?
Yeah, in this particular case, actually the creatinine has been fine, but otherwise still rely on just N-acetylcysteine in the brine. Giving on the day, usually we just try to give it that morning, 1200 milligram, and then 2 doses after. We did use sodium bicarbonate at one point, but at present we do not use sodium bicarbonate routinely because we had some bad experience. Although we are in a process of starting some part of there is a trial.
Another filter.
Yeah.
Open.
No,
Well, so far as I think it relates to this patient, I think Anu had made a very important observation, the importance of hydrating this patient prior to placing the Impella.
Yeah. Yes, and the hydration. I mean, that's a very important issue. That hydrating these patients is very, very important. May not be a long hydration, prolonged hydration. More importantly, that hydration, particularly we tell the patients not be NPO. That's another point. And drink a lot of water before coming in. Like elective patients like this, some patients we give intravenous when they are admitted day before and so, or for some reason they are in-house. And usually it is 1 ml per kilogram. And that basically based on if a patient has renal failure, LV dysfunction, then we go with the half, but otherwise 1. And the sodium bicarbonate actually is not being used in our cath lab at present. We know also that by using the trial of the CARE trial, which we have shown that sodium bicarb and so was used in those patients, and so some of those patients, and clearly that it's not routine at present. I know many centers do use sodium bicarbonate. One of the big issue for the sodium bicarb, too far. Yeah, here. We need a 2-3-0
sodium.
I think the most important part would be in elderly patients, depending on what the creatinine level and what the LV function is. If you have LV function, you can hydrate them almost up to a liter before they come in. If the LV function is worse, which is we are talking 30 and below, then you just have to be cautious, but still giving up to 300 cc just before they come in, or even while they're getting prepped, you can give a bolus of a hydration. The most important point is that you need to give mucomist and do all this preparation even before the dye has gone in, even before your groin shot, because your first kidney injury happens with the a molecule of dye that gets into your body. And the other thing also is you have to curtail on your dye use. Has to be very low dye use. So if you, as long as you can do your procedure, if you can do the procedure between 50 to 70 cc Cath and PCI, I think that's the most important point that we try to emphasize and also do in this lab, that once we have creatinine that is high, fellows already know that most of the time they only do 2 pictures of the left side, which is epicaudal, aleocranial for the left side, and then aleocranial for the RCA. So these views give us an idea of the entire coronary tree, and depending on the creatinine level, we may do an LV gram or not do an LV gram. In that case, we just enter the LV and get left ventricle end diastolic pressure, which gives us the idea about the fluid status of the patient.
All valuable tips, Anu. Sameen, I noticed that only for the proximal segment the balloon really needed a little expansion. The rest were just, I think the rotational ablation had done a wonderful job.
Right, and these kind of cases, we know that it will be will create some dissection because of the calcium and large amount of plaque. And we knew that this case will be a 3-stent case, maybe the 4th one if we talked about the left main. But we show the last picture now.
I think we just have
Rota PTCA, and
we should leave the left main alone based on all this.
How much was the minimum luminal?
Yeah, was 6.47. I think
6.5.
Sameen, any purpose of having an advantage of using the FFR here?
FFR will be negative.
Yeah, for the left main,
left
yes.
main will be,
that you know, we fewer of our.
Good.
Yeah, you want to go a little bit? That's okay.
That's
yeah, that.
Take a picture.
Good. Let's take a picture a little bit. That in some decision making.
Was she there? I don't know if the disease was there. No, which one is
that from some decision making in many of these cases, yes, FFR will be a useful adjunct. But clinically, I think the IVUS and so, I think we need to go a little further. We need this is the 3-stent case. I don't think we can get away from less than 3 stent. A lot of disease.
This is what, a 3028?
Yeah, this is a 3028 Zions.
Zions.
Yeah.
How far you have to go?
Yeah. Go up to the tip. I think we will go with the little bit few millimeter more.
As long as you don't put 4 stents.
Yeah, good. Yeah. The same, deploy at 10 atmosphere. This is the 3028 Zions at 10 atmosphere if need to be. We'll go with the post dilatation.
Do the second stent, right?
Get another one. Yeah.
So Sameen, you've normally in previous cases you've talked about 12. Why did you
10
decide
to 12?
to go?
No, but 10 to 12. I think the distally vessel is like little less than 3O.
Right.
But otherwise, the many of these small vessels, we'll put a, let's say 2.25 millimeter vessel. I'll put a 2.5 Zions and leave it at 8 atmosphere.
Excellent.
Yeah, and then now clearly you are going to put another one so that you may open the mouth of entry, the funnel of this is now 14 atmosphere, which is okay. And we put a second stent, and I know we are just reaching the time, just maybe 1 minute, and third stent if need to be. After the second stent, we'll take a picture, and then we'll decide with the third stent, and Anu then make a point that how we wean from the Impella and so on and so forth.
You can start weaning now.
Good.
Anu, how much time do you normally give them?
5 minutes.
That's all.
Yeah, wish that we have the longer stents available. As you know, the Zions Prime and is the 38 millimeter. We do have a Texas Liberty 38. So some of these cases, the diabetics, the wire came out. That 38 is used. Many of these cases, you know, because of the lot of the traction tension in the system, we need to be careful with the wire, which is not unusual, and the wire tip has been. You want to get a different wire?
Yeah, that's okay. Leave it.
Yeah, where the filter wire?
New.
Yeah.
So you're planning to use another 3028 to overlap?
Yeah.
Exactly.
Yeah. And then you probably will definitely need a one more proximal to it.
Yes, I don't think it is going to cover till.
That's good. Okay, this is always good. Once you have the loop of the wire, it's just works out very good.
But you have to be very careful. The loop is not taking dissection flap with you. Could cause
Well, this
Yeah,
loop
the
in this
entire
case
vessel,
was
yeah.
came in handy to advance through the previously placed stent too.
Yeah, the loop always has to be in the radio opaque black part of the wire. If your loop compromise, the radio loosen, you will dissect and dissect the whole vessel.
Yeah.
So we're covering the dissection created by the post dilation after the rota right now with very nice expansion of
And
the
now
stent.
it's a 12 atmosphere. The
Right.
same thing that, as you mentioned, that more than 12 is no. The rare case, if you go beyond 12, you'll see the dissection. There were more than 12 is no. And
18
then
or 23.
once you have the overlap area, always try to dilate that so that better opposition, because double stent will require a little higher the pressure to expand. So now in this case, we'll just go few millimeter in, and this is the overlap area. Dilate a little bit, another 12 atmosphere.
18 or 23? 18, 23, no.
23.
You cannot do stent boost here because of the multiple metals.
Samin, I've received some emails that a few people towards the beginning of the case, there was some problem with the audio that has been resolved in the archived cases, so that should be no issue at all.
Sure. All right, therefore I think we just take a picture here and then decide what we need to do. Clearly in this patient, you need to just do enough. You don't have to do yeah.
Something very distally beyond the second.
Yeah, that little vertical displacement, we can do a balloon dilatation, which we have already. But I think from our webcast point of view, if it's okay with everyone, we want to stop the case here, and that basically the points which we have made in this complex case, rotablation, use of Impella device, and now ready to remove the Impella, and always take up pictures in 2 views, and this is
Put a proximal stent.
and then we are going to just put a the proximal stent in the end, so that we don't need to be, because we are just about the end of our
Do you
webcast.
use a 3.0 or a 3.5 proximally?
Well, I think it still will be 3.0. That's fine. So everything looks very, very good. And now, Anu, you can, if you just want to show last minute that how you are going to take your catheter. This has been, the P2 has decreased.
How are we?
Good.
Okay.
We're ready to take it out now.
We are not going to do another stent?
Yeah, we may decide. Yeah. Yep. Show the fluoro. You want to show anything on fluoro? And we just
You
finish
can just,
it now.
as long as we know that you can just take it off.
Yeah, very simple. The pulling it just a pull. And after you are done in 5 minutes, downgrade, and then they clearly need some more improvement. So if we can take a last slide of the take-home message, the technical tips for this complex high-risk PCI patients, that LV support and the lesion modification required for us to do safely, and of course LV assist device Impella is very easy, hemodynamic support, high platelet reactivity in Clopidogrel maintenance dose is associated with higher MACE, and therefore we need to modify it by increasing the dose or changing to a Procedural, and of course coming down the pike will be ticagrelor. And lastly, the currently midterm data we know unfavorable for DES in multi-vessel disease, so that if syntax score more than 33, so these patients should be sent for bypass surgery and develop the protocol. Don't ask the patient while lying on the table whether you want bypass. Of course, nobody will like bypass, but we know the right thing to do. Protocol driven, these patients should go for bypass unless there is contraindication. And of course, optimal strategy, and that's our goal here, is try to educate everyone to get the results what we get at Sinai with overall the complication rate of less than 0.4% taken altogether. With that note, Anu, you want to make some last closing statement, and we stop it now.
Yeah, just to say, I think one important point in this particular case was if we are going to do the proximal stent, and especially if you are coming up to the osteal LAD, the best view would be a caudal view, which would be either RAO or LAO caudal. That will tell us exactly and how to place the stent. And you have seen the ease of insertion of the Impella as well as how we can take it off the body. It's just like a pigtail catheter insertion. Any other questions we have?
And with that, our note, my Cath lab staff can collect here. Group with the Vicky, Pablo, Tapson, and of course Marilyn. all of us are really thankful for getting these cases. Sometimes maybe a little nerve-wracking because right from the morning you need to start 6:30 getting the patients ready. But the staff has been fantastic, phenomenal for all the help and able to make these meetings and these live webcasts successful.
Samin, congratulations.
Our fellows, Sham and we have Sandeep, who is actually finishing at the end of this year and will be joining Kentucky, a large private practice group where he'll be doing all these complex cases, I hope, in that small town.
And fellows are the backbone of the program. People ask, how can we do individually 1,800 cases, and so Anu doing 1,000 plus. Is the key is the help by the fellows. They proper patient selection, the treatment before, after, follow-up has really been phenomenal. That despite increasing numbers, the quality has not suffered. And important
it's
the fellows
protocol and the protocol driven.
Yeah. All right.
Samin and Anu, congratulations for another excellent case. Wonderful demonstration of a percutaneous LV unloading with the Impella. Great case also to demonstrate the benefits of rotational atherectomy in a complex case. I want to thank Pedro Moreno for the demonstration of the LipiScan. Finally, for the viewers, please keep sending the feedback. It is clearly improving the transmission, and it will help us modulate the performance better. Our next live case will be on December 21st. We'll see you then, and thank you so much for viewing.